Perfect.
Good to go. We're set.
Awesome. Okay, we'll start with, as we usually do, a round of introductions. If you want to just unmute yourself, we're a pretty small group. I'd love to hear you say hello and those of you who are in the room.
Good morning, Christina. It's Rhonda and Sam at North Valley Hospital.
Hello, Rhonda and Sam. Welcome. Who else is on the line?
Good morning. You got Alex at CBH.
Hey, Alex.
This is Ray from Lake Chelan.
Hey, Ray. Anyone else?
Of course, you got John from North Central.
Hey, John.
And Caroline from North Central.
Hey, Caroline. Okay. And I'm Christina Clark. I think everyone knows me by now. So welcome, everyone. We'll probably have a few more people joining as we move through some of the contents this morning. We are recording as usual, so if you've missed previous sessions, you can catch up. And John will be sharing those after the sessions as well. And so we've already done introductions. Is it helpful, though, to have this tracked in the chat log, John or Caroline? Is that helpful for you? Should we do that too?
I actually already have it tracked on a spreadsheet.
Okay, perfect. Okay, so today what we're really focusing on, just like last week, we're going to have some time to do a little bit of a review of the past session. Make sure that if you have any questions from the previous session, we can address those. The second learning objective we have for today is to hopefully, when you leave the session, you'll be able to use PDSA cycles to test and scale up tests of change. 3, to describe when and how to implement change. And that is our learning objectives for today. So a very quick review from last week. We really dug into the second question in the model for improvement. How will we know that a change is an improvement? And we drilled down into measurement, really, and the process of measurement in particular. So we talked about 4 steps, the first being to choose which measures you're going to collect, and we talked about it being aligned with the aim, making sure that you're following the principles of measurement for improvement, which is those just enough, good enough measurement types. The second step we talked about was to define our improvement measures, and we talked about conceptual definitions. We talked about operational definitions, so numerators and denominators. And we also talked about a collection plan. So who's gonna collect the data? Where are they gonna draw it from? So the real details of how you're gonna do that. Excuse me, I'm just gonna close my door. I hear a lot of noise out there. And the third step we talked about was collecting. So that's when you really take your operational definitions, you take your collection plans and you put it into action. So now you're starting to grab that data. And finally, to learn and act based on what you're seeing. And we looked at run charts for the gold standard for presenting our improvement data. So time series charts, that data over time. And we also took a look at applying run chart rules. And the last thing that we did at the end of the day was to leave an action with a run chart rule exercise so that you could start trying to apply those rules to draw interpretations from your improvement data. So hopefully that's familiar to folks, because that's what we did last week. And I just want to stop and see, are there any questions that came up from last week? Bearing in mind that I'm going to go through one example of that run chart rule exercise. Any questions came up?
Ms. Ray, do you have any other rules for not just run charts, but other types of data measures?
Yeah, we didn't talk about control charts. Control charts are similar to run charts, but they're a little more sophisticated and a little more specific. They require even more data to use. Control charts are just like run charts in that it's all time series data, but instead of plotting the middle value or the median, you would plot the average and use a couple standard deviation lines as well. So 3 standard deviations from the average line. And then there's a couple of different rules that you could apply to that, which are called control chart rules. So you can also Google for that. But other than that, there's not really any rules that I know of for our improvement data.
Tina, I have a question too. I know we're asking our providers to share their measures on a quarterly basis. So for run charts, are you're shooting for monthly, or is it okay to use quarterly data, or is that not enough like frequency to see the variability in the noise?
I just wanted to let you know that Cooley Medical Center is here.
Hey
Sorry
guys.
for being late.
No worries.
Hey, Cooley.
Hi.
So here's the thing about quarterly data. It just takes longer to see the variation in the system because we're collecting less of it. It takes longer to get to 10 data points to apply run chart rules. It's totally fine, especially as a reporting cycle, so that you don't have to go, you're minimizing the burden of reporting. But I would suggest if you're able to at least be taking a look at your data on a monthly sort of cycle. Because you'll be able to take a look at that variability, and that's really important, especially if you're testing out your changes in a smaller time frame or over a shorter span of time, because you could miss some of the nuance of the change that you introduce into the system if you have really long time lags between the data you're collecting.
Mm-hmm.
Is that clear? Does that make sense?
Yeah.
And then one of the things we didn't really talk about is the frequency of data collection sometimes depends or can be changed and adjusted based on where you are in your improvement cycle. So when you're just planning for your improvement, but you're not actively testing any changes, quarterly works great because you're not expecting a whole bunch of change in your system. But when you do move into that active testing and introducing changes, a shorter span of time can give you that nuance and tell you whether your changes are leading to improvements sooner. So again, you get to see that variability. And then when you're done, when you've implemented everything and you've achieved the level of performance that you sought out to do, so you've achieved your aim, then you can move into sort of a sustainability cycle where again, you reduce the frequency of reporting because you're not expecting any significant variation in the system. And really what you're looking for is just to make sure that you're not sliding back into your past performance over time. Any other questions from last week?
Christina, this is John. I'm curious for everyone on the phone. Have you guys used run charts before, or is this completely new to all of you? Anyone?
Hi, this is Vicki. Yeah, I've used run charts for a couple different projects that I have done in the past.
Great. Anyone else?
This is Kelly from Cooley. I have not really had any experience with run charts.
Okay.
This is Rhonda at North Valley. We use run charts, but we haven't been using the rules to demonstrate to the staff just how effective they can be. And so this has really been an eye-opener. Oh, yeah, you know, we've just not using all of it to the extent we need to.
Did you get a chance to test out those rules?
Honestly, no, not yet. But we were just sitting here discussing that on different things that we could use it and check the rules and see how we were doing.
Yeah, especially if you've got run chart rules if you've got run charts, go back and take a look at that. It's super cool when you're able to find a signal of improvement because the run chart rule is there, and it can really like energize an improvement project and make you feel like, yay, we actually did do something good. So why don't we take a look then at What I'm going to do is just go through the first run chart that was in the exercise and go through that as an example. It's tough to do this on a webinar, especially if it's not, or if it's very new to you. It can be a little bit frustrating, but know that that frustration is normal. And it's really just like cooking or baking a cake. It's just applying the rules. And so the rules were in a handout. This is sort of a shortened version of the rules. There is more detail in your handout that was sent out last week. So definitely follow those and not necessarily this. And some of that nuance will come out in the first example. And one of the things that I'm going to do directly after this session is to send out a copy of the solutions sheet, so that if you've had a chance to practice it, or if you haven't yet practiced it but you still want to, you'll be able to compare, what you were able to find in the run charts with that solution sheet. And of course, if there's anything confusing, if there's any questions that come up, just reach out to me and we can work through it together. So for anyone that did get a chance to use the run chart rules, any observations, reflections, something you learned?
Did people, if you didn't use it in your current data, did you go through the spreadsheets and have some questions associated with it? Because I was kind of curious, Christina, I was trying to figure out the third or fourth rule, the runs, where it crosses the median, and kind of the, how is that applicable, or how do you really use that? I kind of got the shift and the trends section, but that rule I was struggling with.
Yeah, that's really common. So let me just back up. That's rule 3, runs, too few or too many crosses of the median. This is kind of just, like you said, the shift and the trend are pretty obvious, because if you're looking for where you have a run chart where the change is planned and expected, you might expect to see a shift or a trend. The runs rule is just a little bit more sensitive if something like that doesn't appear. And it's based on the premise that if you have data points and you draw a middle line through those data points, you would expect them to be evenly distributed in the absence of any changes in the system. So in a totally random system, you would expect them to be randomly distributed, just like you flip a coin, 50% above, 50% below. With a system that's being changed, so you're acting upon it, you might not see that, and that's where the runs rule comes in. So you might see quite a few more over top of the median and quite a few more points down from the median. And so that rule just kind of helps you to infer how often did it cross the median line. And usually where there's an improvement, you find that there's fewer crosses of that line. And I wonder, I don't think I have an example here. No, I don't. Essentially just, you would expect it to cross the line a normal number of times, and that's what the critical table gives you. This is just a more sensitive test of that. And then where it's too many, that's a really rare occurrence where there's too many times it crosses the median. It doesn't necessarily tell you that it's a signal of improvement, but it tells you there's something funny acting upon your system that's making it kind of erratic. And it's more of a tool, just like rule 4 for astronomical point. It's more for a tool for learning and inquiry into what's going on.
Cool, thanks.
Yeah, let's go through the first example. So here was the first example, run chart 1. We take a look at this, and with the rules and with the exercise, we start it with the question, do we have enough data to apply our run chart rules? And remember, we need at least 10 data points to be able to apply our run chart rules. And if we begin counting how much data we have, we find we have 17 data points. And when we calculate the median value for all of those 17 points, we find that it's 9, and we can plot the line through the data points at 9. So we've got 17 data points, we've got our median at 9. We can now proceed with using our run chart rules. So when we think about rule 1, the first rule, 6 or more points all above or all below the median. If we look for that one, 1, 2, 3, 4, 5, we find it in the first few points, 1, 2, 3, 4, 5, 6. And now here's what I mentioned in terms of the nuance. The rules, if we read it from the handout, are 6 or more data points all above or all below the median. If you find in those consecutive points one falls on the median, you just skip that value and move on to the next. So 1, 2, 3, 4. Can you guys see where my mouse is going? Okay, good. 1, 2, 3, 4, 5. Skip that one, 6. So we do have 6 above the median here. So that's a shift. So that's run chart rule 1. So that means we have a signal of something going on. Where that something is in a system that we've planned and are expecting improvement, we can probably conclude that there's some improvement going on in our system, which is great. If we keep looking for run chart rules, we can look for rule 2, a trend, 5 or more points all going down or all going up. We find one right there, 1, 2, 3, 4, 5. So there's a trend. And then if we try to apply run chart rules 3 runs, we have to first start by counting the number of times the line connecting the dots crosses the median. So we find that there's 1, 2, 3, 4, 5. And that first point where it just hits the median but doesn't cross, we don't count that because we're looking for the line that's crossing the median. So when we go back to our rules as we read them, we've counted the number of times the line connecting the dots crosses the median, and we count that it's 5. Our rules tell us that we add 1, so we have 6 runs. That's just the rule, we just follow the rules. And then we look for how many of our data points do not fall on the median. So we had 17 data points in total, and we subtract that one that falls on the median, so we have 16. We take that information and go to our table of critical values, which was included in the handout. And if we have 16 data points not on the median, and when we look at this table, the lower limit, so less than this would be too few, is 5. More than 13 would be too many. Because we have 6, we're within that normal range. So we don't have the presence of this run chart rule. So there it is. We've got rule 1, we've got rule 2. Rule 4 was the astronomical point. That's more of a judgment call. I don't see any evidence of it here. But sometimes it creeps up, and most often when I've seen that pop in, it's usually because we've made a data entry error. And so it's a useful tool to just take a look at, what's going on here and how, what does it mean to us? The last note about that is that we found 2 different run chart rules on this chart. Once you find one, you can stop. Once you find one, it's evidence that something's going on in your system. You don't need to keep looking for the run chart rules. We did it here just for practice in applying the run chart rules, but know that just the presence of a single run chart rule signals that your system is not random. So you've got some sort of signal potentially of improvement if your improvement's planned. So that was just a test drive through applying run chart rules. Are there any questions? I've stunned everyone into silence. Like I said, these rules are just, they're just practice that makes them make a little more sense. They're really fun. If you've got run charts at your organization that you've been tracking for a while, you have more than 10 data points, try applying them and see if you can find any signals. And again, if you have any questions about the run chart rules or anything about data for improvement, just let me know and I'm happy to help out.
Christina, this is John. Kind of a quick question to the rest of the group. I'm curious, knowing that everyone on the call is really a small critical access hospital, how often do you guys think you encounter the astronomical points rule? Because you guys have such small numbers each month. I wouldn't be surprised if one month got thrown out.
John, we were just having that discussion here that most of ours are astronomical. You know, the high, low volume, but you know, high. What do I want to say? High
fluctuation.
Yeah, that's a big fluctuation. You go for 0, you have none, and all of a sudden you have a fall, or you have 0, and then all of a sudden you know, for years, and then you have 1 decubitus. So those are where we have the astronomical, just the one-offs.
So just a note about that, I wouldn't consider that. I know it can seem like an astronomical point, but if you collect data over time, you'll find that it's probably not an astronomical point. What you're talking about is rare events data, and there's actually different ways that we can treat rare events data. And usually it's time between incidents, so time between falls can be really effective. And what you're looking to do is to, for an improvement in a run chart, you would look for a lengthening of the time between events, and that would be evidence of improvement. If there's any questions you have about how you might treat a particular data point, I'm happy to chat with you and to work through that. Probably astronomical points won't pop up as often as you think, and the longer you track the data, the less it'll look like an astronomical point. It might just look like a lot of variation in your system. Okay, let's start with the PDSA cycles, or continue, I guess, with PDSA cycles. Today's going to focus on PDSA cycles. Our last action is going to be to go back and do a PDSA cycle between sessions. But we're going to talk a lot about principles of testing changes, and also when are you ready to implement. So the PDSA cycle is a structured approach to quickly test, adapt, and implement changes. It's used to accelerate learning and improvement. And I know a number of you have used this or are familiar with PDSA cycles. So bear with me if this is review, and also use the chat box to share your own experience and some of the knowledge you have about PDSA cycles. So here is the PDSA cycle, a little more detail than it lets on, really, because within each of the sections of it, plan, do, study, and act, there's a few key questions that we want to be answering each time. So the first is your objective. So we're in the plan section, objective. So is this a PDSA to collect data? Is it a PDSA to test out a change? An example might be tested a patient education tool to see if it's the right literacy level. That's an example of an objective. The question then is, and your predictions are, will this education tool be understandable to patients and staff? And you would predict after you've developed it that yes, it will be understandable and clear to patients and staff. They won't have any questions. Another example could be if you're seeking to maybe test a new process for collecting data on primary care provider follow-up appointments. You might have a question about, will this process yield the data we need? And questions could also be, will it take longer than 2 minutes to complete? So those are examples of questions you might use in your PDSA cycle. And the prediction part really is the most important part, because this is where you're theory building. This is where you're driving at new learning with each test of change. So as you carry out your test, so you move into the do part and study, what you'll be looking at is, was your prediction right or were you off? And that's where you learn something new. So the last part of the plan is the really nitty-gritty stuff, the who, what, where, and when. So it's as detailed as Mary's going to print out the patient education tools, leave them in a location that's defined. So it's all that who, what, where is this going to happen, when is it going to happen, what date are you going to test it on? And the last part of the plan is the plan for data collection. So that's the stuff like if you had a prediction that it'll take less than 2 minutes, you want to time it. If you have a prediction that it's going to be clear to patients and understandable, you might want to track some observations about what questions came up, how many questions came up, was there any confusion that came up. So when we talk about a plan for data collection, when we're talking about PDSA cycles, this isn't our measurement for improvement. This isn't the measures that we set, the ones we choose and define and collect. These are a smaller unit of observation type data that we just use during the course of this very short cycle. When we move into the do part of the PDSA cycle, it's just carrying out that plan, the who, what, where, when. We document any problems, any unexpected observations. So how long did it take a patient to read the form? How long did it take us to try and collect the data that we wanted? And then we start analyzing that data. The study is completing the analysis of the data, comparing what we observed to what we predicted would happen, and summarizing what we learned so that we can feed that into the next step of the PDSA cycle, which is action. So ACT is where we decide what changes we're going to make to this initial cycle and what will that next cycle be. And a couple of next steps are usually that we adapt the change. So it worked a little bit, but we need to make some tweaks. Abandon, maybe it didn't work at all, or maybe the risks were too great. Or adopt, and that's where we move into implementation. And we'll talk in a moment about when you're ready to implement. So here's a couple principles for testing changes. The first is to start small. The second is to build knowledge with each test. Third is to scale up our tests over time. 4 is to test over a wide range of conditions. And the 5th is to implement when we're ready. So I'm going to break these down. So starting with starting small. Here's a nice little handy table that kind of gives us a little bit of guidance about how small do we want to start our scale or our first test for a change. So this table guides us by giving us a couple of parameters. The first is our degree of belief that the change will lead to an improvement. So say we have a low degree of belief. We haven't really, maybe we found this idea in evidence, we found it from another organization, but we don't know if it's going to work at our site. So we have a low degree of belief that it will lead to an improvement. Maybe the cost of failure is small, we figure. And the commitment within the organization, there's some. Maybe we have a couple of champions on our improvement team, but no one else really knows about this change, and so there's not really any commitment. So in that case, we would be led to a very small scale test. And when I say small scale or very small scale test to change, what I mean is one patient, one provider, one form, one day. So use the rule of 1 to guide you on how small you need to make the change. Especially when we're new to PDSA cycles, it's very easy to get the scope way too big. And it seems kind of silly to make it this small, but this is really how you drive change forward and what makes the PDSA cycles run a lot faster when you start out really small. So that table can be handy for guiding what scale of test you're looking for. Any questions about that?
Tina, what's the distinction when you say implement? Are you saying implement once you've tested things and you know it works, or you're saying implement the test across your whole patient population? Or
both. So I'll come to that, and maybe I
Okay.
didn't understand your question fully, but when we come back to implementation, let me know if we haven't covered it.
Okay. Mostly just that I see everything in this grid says test except for that one box, and I'm trying to understand what the difference is, but I'll listen.
But you're right on. So once you've tested you start really, and we're going to talk about, is that the next piece? No, we're going to talk about scaling tests of change. So we started with a really, really small test of change, and that minimizes the cost or the risks of failure. It helps us build commitment within the organization because more people get to experience it, get to feed their ideas into it. And as that happens, we begin to build the degree of belief that that change is actually going to work here. It's actually going to lead to an improvement. So we're scaling the tests of change up over time. And when we have that high degree of belief in the commitment, that's when we're ready to implement. And we'll come back to that in a moment. So the second piece for principles for testing changes is to build knowledge with each test. And I'm going to ask you guys to follow along with this one because we're gonna do the study together. So let's say our aim is by January 2020, we aim to reduce 30-day unplanned all-cause readmissions by 25%. So one of the change ideas we're going to try is 30-day primary care provider follow-up after hospital discharge. Our rationale, and this is optional, you don't need to put this in. Our rationale, though, is that primary care provider follow-up within the 30 days will improve care continuity and ultimately help us reduce our emergency department readmissions. So we're ready to start our first cycle, our first test of change with this change idea. So we document in our PDSA our change idea, 30-day primary care provider follow-up after hospital discharge. We start with our questions. Will the patient be seen by a primary care provider within 30 days? Will the follow-up coordination take longer than 5 minutes? And we want that, we're curious about that because we know that we probably don't have the capacity to do this if it's much longer than that. And this kind of acts like a balancing measure in that sense. We want this to be an effective process, but also a sustainable one. So we're going to track time. Then we move to our plan, the who, what, when, where, and the measurement plan. So who, Nancy, with the first patient discharged on June 17th. What will she do? Nancy's going to advise the patient to follow up with a primary care provider. She's going to call the primary care provider to request follow-up. She's going to do that at the hospital registration desk. When? On June 17th. And the things that she's going to track are time that it took for the conversation. Was the call successful to the primary care provider office? Yes or no? And was there follow-through on the follow-up appointment? So that would probably be delayed by 30 days, right? And then Nancy carries out the plan. So Nancy carries out the plan. The patient reports to her they don't have a primary care provider and didn't want to follow up. So Nancy referred to a case manager on duty, but they weren't available, and the patient ended up being discharged without a follow-up plan. So when you take a look at that, what are some of the things that you might summarize? And what would be your next steps, your next cycle from this? Feel free to jump off mute.
I would say one of the first things, this is Vicki, one of the first things is we need to probably get her, we need to get a PCP, a way to get a PCP for this person. Yep.
So we need to get a way for this person to have a PCP. So what might be your next steps in terms of a follow-up, cycle 2 for this change idea?
We would schedule her with one of, well, if she didn't have a preference, we would schedule her with one of our PCPs at our hospital or clinic.
Great. So that could be a follow-up cycle that you do. So if you tried to run this cycle again, it could be that you'd encounter a patient who does have a primary care provider. And so in that case, a different process would apply. But in the cases where a patient doesn't have a PCP, you could then use this alternate test cycle. So what we've learned in this particular case is that we were surprised by the fact that this patient didn't have a PCP. Of course, we might not be surprised by it, but we failed to consider it in the plan initially, so now we're going to develop an additional process for that. Any other thoughts about how you might act? Some other considerations?
Okay, since no one else is talking, this is Vicki again. We would have to have a plan on how to do the referral to the case manager when they aren't on duty. So is there some other way? Is there someone else that follows up? Is it assigned to someone else? Can the case manager follow up tomorrow and schedule an appointment? There's lots of different ways with that, but.
Great, yeah. That's a really good observation. Anything else that stands out?
Christina, in addition to what Vicki mentioned, would it be appropriate to just try again on 6/18, like without changing your process, just to see how often patients might report not having a PCP?
Yeah, you could. You could absolutely do that. And you might want to collect, you might want to change your measurement plan to collect, what number of patients didn't have a PCP.
Christina, how do you handle in this circumstance a patient just didn't want follow-up?
Yeah, good observation. So the patient didn't want follow-up. So that's something, again, as an improvement team, you would sit down and you would think about, well, we know that follow-up improves care continuity, and we imagine that it probably will, our prediction is that it will ultimately help us reduce ED admissions. So how can we handle this? And that's something that you can brainstorm together. Maybe it's, like Vicki said, working on that case manager referral. Maybe it's some training in motivational interviewing to try and elicit, what are the beliefs and the intentions of the patient, and try and respectfully guide towards some change there. So there's all kinds of things that we can learn from a single test of change that can feed into the next cycle. And so with something like this, over time, what I could see emerging is a bit of a flow or a process map of, if this, then this, in terms of how you can support that connection between a patient who's being discharged and connecting them to a PCP in a number of different scenarios. Any other thoughts about this example? Okay. The third principle for testing change is we scale up over time. So we talked a little bit about this. When I talk about scaling a change up over time, I mean that sort of the scope of the test. So one patient leads to two patients, maybe leads to, when you're increasing confidence, leads to patients over the course of the week. So let's take a look at this diagrammatically. If our change idea, we're still using the one of 30-day PCP follow-up. So our first test of change is very small. So we do a follow-up call with the first patient discharged on Tuesday. If that goes well and we're collecting our data, we're learning about what's working and how we need to adapt this change, then we move to a small scale. So follow up with all patients week 2 that are attached to our clinic. So we're looking at a subgroup here. And we're starting to test over what we call a range of different conditions. And I'm going to come back to a slide on this in a moment. A range of conditions is essentially that if it worked on one day with one patient, but then we start scaling up to different patient types, different staff types, different sites, times of day. That's our range of conditions. And we want to really make sure that our change is bomb-proof by making sure that it works in not just this particular case, but across a number of different cases. So as we're scaling up, we're testing, maybe now we move into all patients, not just the ones attached to our primary care provider clinic, but all patients over the month of June. And again, as we're scaling up, we're testing over a range of conditions, we're building our degree of belief that this change will in fact lead to the improvement we're seeking. And that's when we're ready for implementation. With projects like this, there's going to be multiple scale-up tests of change. So what I mean by that is that you're going to be working on, say, 30-day primary care provider follow-ups. And that's going to be a sequence of its own ramps of tests of change or PDSA cycles, so where you're starting really small and growing and moving to implementation. But you have other changes that you're working on too that go through the same sequence. So say, using your information systems optimally, patient self-management support, and what's in your package of changes or your change ideas. Those are all of the different tests of change that you're going to be running, and you're going to be running these ramps as well for those. Coming back to testing over a range of conditions, here's just some examples. So testing over different times of day or times of year, season, so flu season, or over a holiday season, maybe in the summertime. Testing across all staff experience levels. So if it worked for someone who's super experienced, does it also work for someone who's fairly junior? Different sites, if you have different sites, if it works in one site, that doesn't necessarily mean it's going to work the same at the other site. Similarly, different settings. So if it's tested in an urban setting, it probably won't work the same in a rural setting. So if you are trying to sort of move it over or spread it across settings, you'll want to test across those conditions. Different technology platforms and different population groups. So our example previously was we had a patient who didn't have a PCP. Does it work for a patient that has a PCP and a patient that doesn't? Maybe different disease group patients, so COPD patients, genders, different ages. So we want to be testing really thoroughly so that we can increase that degree of belief. And then we implement when we're ready. So testing is used to evaluate a change on a temporary basis, but implementation is really used to make that change permanent. So when are we ready to to implement a change, to make it permanent? We use this table to look at if we have a high degree of belief, our cost of failure is small, and we have strong organizational commitment, that's when we're ready to implement. But this is just a guide, this table. One of the things that's great about testing over time is as you're increasing the scope of those tests of change, you're naturally pulling in more staff members, and over time getting their ideas and their input, and they're adapting the change, and they're developing ownership in that change. So your commitment within the organization often grows through ramps of tests of change. And then of course, the degree of belief is a concept that depends on, first, the extent to which the prediction is supported by evidence. So that's really just your test of change. You're setting predictions, you're testing it out, you're learning, and you're adapting it. And if when it works, then you have that data, the observations, and it increases your degree of belief that it's going to work. And then the second piece is the similarity between the conditions under which you obtained the evidence, so you did those tests of change, and the conditions to which the prediction applies. And what this really means simply is that you've made this change bomb-proof, so you've tested it under a range of conditions. And then finally, what is implementation? We can do implementation also as a series of test cycles. And implementation is really the same as testing a change, except it includes a few extra parts to make it permanent. So when you're ready to implement a change, you begin the process of standardization. So you update your policies, your procedures, your hiring practices, all that stuff that standardizes the way that you use this change. You want to make sure you're documenting the change. Maybe there's protocols that you need to update, job descriptions that need to be updated. When you're ready to implement, you're also ready to start training all staff in the new process or the new change. You also want to think about resource allocation. So often when we move to implementation, it requires new forms, training, communication, and that all takes time, and sometimes it takes a little bit of money to be able to print those. So thinking about how we're going to allocate resources for that. And then lastly, continue to use your improvement measures over time. So the second question in the model for improvement and that we talked about so much last week was our measures over time. So we're tracking data over a month or over the quarterly cycles. Once we implement a change, we want to continue to measure. And I talked about earlier how once you've implemented, once you've achieved your aim and you've implemented all your changes, you still want to continue to track that data to see if you're sustaining your changes over time, but you can do it less frequently. Caroline, coming back to the question that you had about implementation, does that answer it?
Yeah, I think it does. I think I was viewing your grid as a kind of guide of where you begin based on your organization's belief and buy-in. So I guess a question for me was, what if you think it's going to work and it's low cost and your organization is already super committed? You don't move straight to implementation, you still test, right?
I probably wouldn't, just because, like I would test first, just because I could be making some assumptions about, what is the actual commitment? I don't really know if it's untested completely. What is my degree of belief? I don't really know. I'm really confident in it, but,
Yeah, that's true.
Yeah. So I think it's a rare case where you would just be ready straight to implement. Something like a pay raise. You're going to have strong organizational commitment. Degree of belief that it's going to work could be really high, right? But there's probably some unexpected budget costs that could come up and something like that. So you may wish to think that through or test something like that. Any other questions about PDSA cycles, the difference between testing and implementation, scaling up tests of change, principles of testing change?
Christina, this is John. I'm curious, knowing that PDSAs is kind of, you're testing something that's a little bit of a risk in everyone's leadership on this call. How do you manage going through PDSA where you end up scrapping the idea and working with your organization and your department to understand that that's okay and that's just part of the process? Does that make sense? Can you hear me?
I can hear you.
Has any organizations dealt with that before? I know when I've worked in clinic management, I've had this fear of sometimes you're working so hard to get your staff to buy into the idea that you have this fear that if it fails, that you're going to have to deal with the repercussions, but you kind of have to be used to that to do this kind of work. Anyone have thoughts on how they manage that?
I'm really curious to hear people's thoughts on that. And I would just add my thought, which is that small scale tests of change are really the way to break that down and reduce that cost of failure. Often organizations have a long memory of what changes didn't work and whether an organization is likely just to abandon the change because it didn't work, or whether they're going to stick to it. So breaking the change down into really small scale tests and building that commitment over time, managing that risk is one of the strategies of implementation, or sorry, of testing changes.
This is Ray, and Christina is correct. I think the ones that you implement full tilt is the ones that you have good confidence that it's going to be a sustainable change. It's the smaller ones where you're going to say, we're going to try this and we're going to see what happens. Maybe this is a tactic that we're going to be able to use. And if you say that up front, it's, you know, they understand this is a trial and we're trying to find our way. If we go full tilt, implementation, full court press, and then it fails, the next idea you have is not so welcomed.
Mm.
This is Vicki. I agree with Ray, although those that know my personality know I'm a full court press right out of the box type person, and they do fail. But I think one thing that has helped is to then go back and say, okay, let's admit that you might have went a little too fast, too furious, and say, what would work? An example of that would be, for us, would be like the TCM calls to the other clinics. At first, we were calling for everything. I designed it to call for everything, and then it's like, whoa, that's not going to work. So then we chose 4 main diagnoses that we were going to call for instead. So I scaled it back a little bit, and we had some good discussion on that. And just sitting here now, Alex and I are thinking, okay, maybe we need to do smaller tests of change and do 1 diagnosis. Are we making the call on that instead of the 4 to get better compliance and then kind of build over time, like you said? So, yeah, I have had failures, lots of them, but if you listen and usually just back up a little, take something off the plate, then it seems to go a little better.
Mm-hmm. Yeah, I totally agree with that. And it's also a really breaking it down into a small scale test, just like both you and Ray said, is a really good strategy for bringing on board some of your resistors. It's like, okay, you don't think this is going to work. Let's try it. Let's just test it out. It's really small scale, and it gives them an opportunity to shape the change too, and also to manage some of that resistance.
This is Ray again. Some things that I've implemented doesn't have a lot of N to it, a lot of numbers, and so we've had to do a complete implementation and just kind of wait it out over time. And it looks like, oh, this is not working. And then we just kind of wait it out and keep going. And then we found out that it does work. And one of the things is, the project I'm thinking in particular is like, we're installing life alert buttons, or these like fall buttons. And there's not a lot of people that are using them, but we have a lot of interest. And so we do a lot of work trying to install these in people's houses, and it felt like it was a failure and this is not working. And then as we've done this for like 5 years, it's actually like now we see like a curve of upward, like this is actually beneficial.
Mm-hmm. Yeah, that's a cool example of it's tough with technology to test it sometimes, or infrastructure to test it before you implement, to be able to test towards implementation. And so sometimes you just have to go for it in that case and just make sure you're measuring over time. And with some stuff, outcomes take a really long time to show themselves. And sometimes there's process measures, though, that we can look at that give us a better sense of how we're progressing towards it. But that's a great thing to keep in mind. Any other questions?
Christina, I appreciate the reminder that even testing with one patient at a time is a good way to start. Like, part of me would have I would have forgotten that that's actually useful. It would have seemed too small. I'm curious on the ramp. When do you, like, I'm thinking about the measures that we learned about last week. So do you only move up the ramp when you've seen enough changes with your run charts? Like, how do you decide when to move up the ramp?
Yeah, that's a great question. So remember, we talked about two different levels of measure. One's going to be observational measures at the PDSA level. The other is your project level measures. So those are your indicators. You're tracking over time. With some tests of change, with most tests of change, especially the small ones, you're not going to see big movements in your project level measures. That's going to take a little time. And sometimes it takes until you fully implement it across the enterprise before you're actually going to see some good movement in your project level measures. Sometimes it takes a whole suite of changes. So what you have to rely on as your guide when you're testing changes is that sort of concept of degree of belief and the PDSA level observations that you're tracking.
Gotcha. Okay.
Okay, I think we've just got about, we're at time here. So I'm just going to ask everyone, I'm going to pull up the poll before you have to skip out to get your feedback on today's session. And when I do that too, I'm also asking for everyone to complete a PDSA cycle over the next week and to share that with us next week. So I'm going to send out an email with the template that you can use and some other instructions, but really just a really small scale test of change would be awesome if you can do something like that before the next session, and then we can share those together. So the poll is up. Whenever you're done with the poll, feel free to leave. I know we're at time if you have to leave already. Huge thanks for joining again today. Thanks for your questions and comments. Our next session is next week on Tuesday at 8.
And just a reminder, all of this stuff will be posted to the Healthcare Communities portal, including the recording and the slides.
Okay, I think we're good.
All right. Thanks,
Sorry,
Christina.
I have to run to another meeting, but
See you next week.
yeah, sounds good.
No problem. Thank
Bye,
you
guys.
all. Bye.